that working? Yeah. Good morning, everyone. We're going to get started in just a minute. So just so you know. Ready? Okay. Good morning. Thank you all for being here. Welcome to the second day of the Sections Retreat. We're doing things a little differently today. We are actually having this as a webinar too. So you all are part of our webinar, ASPPH webinar. This webinar is focused on advocacy and action, advancing public health in a shifting public policy landscape. I'm Tim Leshin. As many of you heard yesterday, I'm the Chief External Relations and Advocacy Officer here at ASPPH, and I'll be moderating today's panel. Usually it's just me up here, but I phoned a couple of friends who will be on the screen for us in a minute. I want to really extend a warm welcome also to all the folks who are online. I think we have hundreds of people online as well, which is great. So the ASPPH webinar session is being recorded, just so you know, and you'll be able to see it on our website after the meeting. If you're joining virtually, please use the Q&A section to ask your questions, and then we'll address them later. For those of you who are in person, we'll have time at the end for questions from the audience. But you'll need to use the mic, which Jessica will pass around. Okay, let's begin. There are our guests today. I'll just quickly introduce them now. I'll say a little bit more about them. Mark Miandusky's in the upper left corner. He works for Cornerstone and represents us on Capitol Hill. He has many years of experience working on the Hill and then as a consultant for us for the last 20 years. If any of you were at the annual meeting, you might have seen that we gave him a special recognition award. And we have Che as well here from Burness Associates. They represent us in terms of our marketing communications work. So we're really lucky to have them here. So I want to get going and start. Oops, there we go. I'm not seeing my slides coming up on the big screen, but so I want to just set the stage real quickly in terms of what we're seeing in Washington. We've seen executive orders that are dismantling functions for public health, excuse me. We've seen a proposed 15% cap on indirect costs, which was mentioned yesterday. And we've seen structural shifts at CDC and HHS that are really troubling for public health, including the change at the ACIP and the Vaccine Advisory Committee, which has become a hot button issue in the last few days. Meanwhile, we've seen that the funding allocations for this year, fiscal FY 2025, are not clear yet because we had an appropriations bill. They passed what's called a continuing resolution and set certain levels of funding, but the administration is not necessarily choosing to follow those funding recommendations, which is not the way the process is usually supposed to happen, right? But we've also seen the passage in the House of the big, beautiful act, the reconciliation package, the tax package, which has some troubling provisions in it, and Mark will talk more about that. And now the Senate is trying to pass it by July 4th, followed by what will be a conference between the two houses, it seems. So a lot going on. Let me just, and then these are some of the actions that we've taken at ASPPH. You know, we've worked on this federal indirect cost issue, the 15% cap. We saw a good decision in terms of the court ruling in our favor, providing a permanent injunction, ending that 15% cap for now. We'll see how that plays out in the courts going forward. There'll be a live hearing for that case coming up in July here. And then we've also been working on the Hill and making sure that we are representing you. We have brought deans to the Hill, as I said yesterday. We've asked all of you to be engaged in the advocacy effort, and we've had a couple of wins. So we've seen the introduction of the Hepatitis C Act, as I said yesterday, which would really provide a great win for public health if we can get that bill passed. And we've really been working hard behind the scenes to try to make sure that some of the funding for the programs that you all care about continues. Oh, this was the hepatitis C. I missed the slide, excuse me. This was our event with Senator Cassidy and Dan Holland. They both came and talked about their bill, and we're now advocating to move that bill. We've also been providing you with materials to use either in advocacy or with your local communities. This is one of our reports, and you feel free to use the QR code that really outlines the actual impact to all the agencies that you care about, NIH, HRSA, CDC, and the like, since the new administration has come in. We wanted to make sure you had the facts and could see the damage really that we're seeing in terms of the pushback from this administration. Now, fortunately, there have been some good lawsuits recently that have reversed some of the cuts to the grants that we've seen at the NIH. And that's a good step forward, but not sufficient. We'll have to keep working on that. And then we did our Broken Lifelines report. This gives an economic impact perspective on how the cuts that we've seen are not only affecting you all in the research, but also local economies who rely on this research funding. So we really wanted to make sure you all have these materials in order to make the case to your members of Congress, and we hope you will, and others. So now we're going to turn to the panel discussion. Let me pull up my notes here, excuse me. There's more work to do. Congress is finalizing the budget. ASPPH will continue to be a strong voice for evidence-based policy and public health funding. But now let's hear from our panel. I'd like to welcome first Mark Miandusky, who I mentioned works for Cornerstone and represents all of us. And I'll let Mark chime in first. Go ahead, Mark.
Well, thanks, Tim. And it's great to be with you all. It's going to be 106 degrees, feels like temp in DC today. And so I'm very jealous that my old skiing spot in Park City, I'm not there with you. So, but it's nice to join you this way. It's an important discussion to have, given this is really an unusual year. This is going to be my 39th year doing budget advocacy in DC. And we've never seen a year like this. We've been through some, the Reagan years, the Newt Gingrich contract with America years, and this is by far the biggest, kind of change we've seen to, probably the future, the existing and the future programs that we worry about and nurture and try to support and grow. I always like to start with a quote that I stole from one of the deans years ago. It is that advocacy is the first step in implementation of public health science and research. And you think about that, it's like you do all the research, you do your, get things published, but then if you actually implement programs, you usually have to get a budget approved, maybe start a new program, get a law passed, create a new authorization, maybe change a rule or regulation to move the science forward. So, just the skills that we're going to talk about today are really critical this year more than ever. And some of the tools that we normally use are a little bit challenged this year, and we'll get into that too in our discussion. So, normally we have to play both offense and defense, and this year it's mostly defense, unfortunately. For many of you who've been spent years in this field, you are watching programs and strategies and surveillance systems and infrastructure, that you've supported and nurtured over the years being threatened and sometimes eliminated already in a matter of months. And thousands of staff at HHF are being riffed as they downsize key operating divisions like CDC and reorganize a lot of the public health service under a new administration for a Healthy America, which is Secretary Kennedy's vision for how to reorganize HHS. For those of you who are new to this is not a normal year. This is like a bombshell of a year for us, especially kind of the way this administration came in, very well organized, in implementing kind of a plan through the executive action, without normally going through the Congress. Normally, you'd see a president propose a new budget. He would ask Congress, "Can we cut these things?" And what we've seen is a different sort of a year that we've never seen before. We call it the flood the zone strategy. I'm sure you've all heard this, by the executive branch to move forward with hundreds of new policies, driven really by starting with executive orders that the president started signing on day one. And they resulted in thousands of grant cancellations that were largely identified by this new organization called DOGE. And we were all watching, Elon Musk's participation in the election process and, kind of dreaming about creating something called Doge, and we didn't really know what that was going to be. And they came in and just, kind of handed over the car keys to Elon Musk's operation. And they went through with, software and identified thousands of grants that, kind of violated in their minds the DEI executive order, diversity, equity, inclusion, and canceled these grants overnight. There's a lot of details we can get into about what the Doge is doing, but I don't think we're at the bottom yet of some of the action, and that's something with us in the advocacy community, worry about. Is it over yet, and when can we kind of start rebuilding? In addition to having the pleasure to represent schools public health for 20 years. I've also represented all the state and local or state health departments and territorial health departments, or ASTO, since 2009. And we've gone through billions of dollars in clawbacks of money that was appropriated that they thought they had to spend over the next few years, that were, canceled, with, 30 days notice to basically close out your grant and stop spending money, which resulted in, hundreds of rifts at the state health departments, and then also consequently downstream to local health departments as they spread that money to their partners in the public health community. So I also run an immunization coalition for 20 years, and so now we're getting it with the ACIP changes that Tim kind of referenced here. So it is very much the system is on overload, and why that's important to say all that up front is because what we normally do in the keys to advocacy is to run to the Congress, and that's how the system is set up. The administration proposes a budget, and Congress receives input from the public, and that's what they're set up with committees to write appropriations bills, to write authorizing bills, and we're supposed to be participants in that process, and we always are. In this case, what we've seen are a lot of these budget cuts kind of happening without really going through sort of a congressional approval process, because there are FY25 grant cancellations. And given that we call it the trifecta, where Republicans control the House, the Senate, and the White House, the committees of jurisdiction are largely letting it happen. They're starting to come around. We're having hearings now, including the secretary was up the other day, the OMB director was up the other day, and Democrats raise their questions, and they participate in the process that way through hearings and writing letters. But the Democrats don't really have much power, so we're really stressing to work with Republican representatives to just raise your concerns about budget cuts, explain to them what these programs do that we're trying to defend, what the surveillance systems do. And that's really one of our key strategies right now. And the other one's probably a press strategy, getting articles run, both on the positive and the negative side. So when there's budget cuts, getting articles run explaining what the impacts are, so that constituents of these members who are voting on these legislation, later on in the process, understand what these programs do. We also like to flatter, as one of my colleagues says, in the press, members who take up our causes and champion them. As Tim pointed out, Senator Cassidy and Senator Van Hollen, are sponsoring the hepatitis C bill. So we want to make sure they get good press coverage in their home state papers in Maryland and Louisiana, that we thank them for their support of public health programs. And that's really important, because every member's office, reads their press clips every day, and they like to see, what the good and the bad and the ugly is. And they really like seeing when their constituents, thank them and support them. They don't have to be committee chairs, they don't have to be senior members. There's a relatively junior member, Julia Letlow in Louisiana, who, is during the Appropriations Committee hearing, she's a Republican, said she was concerned about cuts to breast and cervical cancer and asking the secretary, will you work with me on that? We'd like to see her get some good press, for some of those kind of things. And those statements and her action on that committee. So, what that leads me to, and I'm gonna kind of close out here in a second, is the other avenue which ASPPH participates in is when the Congress doesn't take action. The last resort is kind of the co-equal branch of government is the courts, and we've seen an unprecedented number of court cases filed, over 250, resulting in maybe 150 plus injunctions to stop implementation of the executive orders. And we normally don't have to do that. It's a very unusual process and something we don't like to have to do. It's expensive, but this is a year that we're fully engaged in that as well. So let me just kind of stop there. I know we have a lot of great questions to get to, and I look forward to helping us all decide what we should do and what we can do to be effective advocates. Thanks, Tim. Back to you.
Thanks, Mark, very much. Really appreciate that. We are now going to move on to Jay Parker, who's the Senior Vice President at Burness. Jay?
Thank you, Tim, and thank you for having me. Something that Mark said really stands out for me. I used the word unprecedented so many times this year that I was like trying to find another word for that. And if anyone there in the room has any ideas for a term we can use, please let me know. But if we take a step back, let's say 6 months ago, and a new administration's in town here in DC. Of course, we knew during the campaign there was going to be policy changes and that sort of thing. But there was still a very high level of uncertainty. We weren't really sure how these things were going to play out 6 months ago. Fast forward to March. We went through a period of true radio silence, right? Agencies were being shut down, reports weren't coming out, research wasn't coming out of the administration. And there was just a real quiet point in terms of public health information. So I would get with reporters and meet with them and talk to them, and they're like, look, nothing's coming out of the administration. Do you have folks that will talk to me? Because what was happening on the public health side as well is that leaders in public health weren't responding to reporters either. Of course, there was an understandable level of fearfulness, and folks didn't want backlash or retribution from the administration, which was a real concern. And so there was a continued period of we're not really sure how this is going to shake out, and folks weren't responding. Let's move forward to today, and we're talking about a very firm understanding of where we are with the reconciliation bill, the big, beautiful bill, as it's known. We know what's at stake now. $1 trillion cut to SNAP and Medicaid, and so on and so forth. And so what we're seeing from a media and a comms perspective is that now that we see what's happening and what's going to happen and continue to happen, is that leaders in public health are finding their voice. They're starting to speak out. They're starting to get engaged. They're talking more. The partners we work with are putting out reports. They're putting out research. They're putting out poll findings. Tim himself has been engaged in press a lot, and we're seeing a lot of leaders being active on their LinkedIn accounts, posting content and that sort of thing, which is really good to see. We're also seeing leaders in podcasts now doing things they've never done before and talking to new audiences and trying to do that work across the aisle. So we have this aspect of like the stats and the data and the research, which public health has always had. But now, and I can't say this enough, everyone in that room has to become a communicator. It's critical. Like now is the time. Everyone has to get active, get engaged, find your voice. I have a few examples we'll talk about in a few minutes, but in addition to the stats and the data, we have to include the human element. We have to still tell stories about people. The beauty of telling stories about people is that it's engaging, it's memorable, it helps to get a point across, and it really brings the data and the stats home. So I have a few examples I'll share in a few minutes, but I'm really looking forward to the discussion.
Great. Excuse me. Thank you, Jay. Appreciate it. Yeah, Jay has been quite busy this last 6 months for us, helping us work with the press and whatnot. So I'm going to kick it off with a few questions, and then please be thinking of your question, and we'll also see if there are any from online. Mark, I'm going to start off with a hard one, and Jay, you can weigh in too. There's a new term they are calling the gold standard of science. Can you talk about what you think that means?
Yeah, I'll take a lead on that. And ironically, we just saw a document come out about 2 or 3 days ago, and you should all look this up because it's important to everybody. So came from the Office of Science Technology Policy. It's up on their website, and I'll get the link over to you, Tim, so you can distribute it. But it asks within 30 days for each federal agency that does science to come back with a guidelines, for their research portfolios that is conducted in a manner that is, and they have 9 tenets of this thing, and I'll kind of just rattle them off quickly because I'm sure we'll all study this and we'll be interested in see what these plans come out look like. But one is reproducible, number 2, transparent, 3, communicative of error and uncertainty, 4, collaborative and interdisciplinary, 5, skeptical of its findings and assumptions, 6, structured for falsifiability, I can't even say this word, falsifiability of hypotheses, and 7, subject to unbiased peer review, 8, accepting of negative results as positive outcomes, and the last one, without conflicts of interest. So we've been kind of hearing this term for a while, and we've been wondering what do they mean. They've now put it into writing, and this just came out this week. So I think, again, this is a directive to federal agencies to come back to them. So like NIH, National Science Foundation will have to, develop their own grant guidelines that, kind of complies with this, essentially executive order from the White House. So let me stop there.
Great, thank you. Chet, did you want to weigh in?
I think Mark covered it. I had the pleasure of listening to the Senate committee hearing with Secretary Kennedy, and this topic came up. And science has become partisan, which is really, really unfortunate. And so I'm sure we'll talk about it more, but it's important to lay these things out for our various audiences, right? Sticking to the facts, sticking to the data. And that's something that we talk to our partners about. But I really don't have anything else to add because I think that there's going to be a level of subjectivity, unfortunately, to what gold standard science is.
Yeah, and I think when you hear the definition that Mark read out, it sounds reasonable on its face, but then it really depends on what do you mean by all those terms. So we'll have a lot more interpreting to do. Mark, there's been already a lot of talk here about the changes being made at the FDA, at the CDC and the NIH, and real concern about indirect costs. Can you talk a little bit about that?
Sure. Certainly, an indirect cost, I just want to remind folks that this is not a new proposal. Trump proposed this in his first administration's budget. And as a result of that, it was quickly swatted down on a bicameral, bipartisan basis by the House and Senate Appropriations Committees. And they put a provision in the bill then, in the Labor HHS Education Appropriations Bill, which is the annual bill that funds, NIH and CDC. It's still there. It's still even under the continuing resolution. That law is in effect that says you cannot change the indirect cost rate. So they can't propose. I mean, they're going to follow the law. And there's obviously lawsuits, and ASPPH is one of the plaintiffs on this one with AAMC. With that, it has to be done by the Congress. They can't just go in and just do it. But it has triggered, probably, unlike the first term, this term, probably a new round of congressional interest in like, okay, well, maybe these indirects are really too high, and maybe we should have some new approaches to it. And there's different work groups that have been working on this. And, you can, at the bottom line, you have to cover these costs, whether or not, you're running if you're running a lab and you're running clinical trials, they're expensive. And that's why those indirects are high. If you want to just charge those costs to the direct portion of the grant and not the indirect, they could do that, but this notion that they're just going to cap these costs the way they are, and then the institutions have to kind of eat those overhead expenses. That's obviously going to lead to less research, and I don't think that's where it's going to end up. But let me just stop there.
Can you talk a little bit too, Mark, about what we're seeing in terms of the changes in the structure of NIH and the structure of CDC?
Yeah, sure. Well, yeah. So what we're seeing with CDC right now, especially because that's happening first, is and this really kind of was driven off this Doge exercise where they came into CDC and started a round of asking folks to take the fork in the road and to, reach higher. And, this is part of the overall reduction for HHS to reduce that agency's total FTE level about 20,000 people from 82,000 to 62,000. And, then they got over to the CDC and they decided they would just implement, in addition to that, RIFs, and then people were immediately furloughed, subject to being, RIF taking place later, and that's also being intervened by the courts and with a temporary restraining order. But we've seen, wholesale, what you call them, within CDC, there's 10 centers, and so within those 10 centers, there's only 4 surviving center directors. The others were let go. They gave them the kind of this option of to relocate or and they basically got rid of them. And then within the centers themselves, scores of divisions, and then below that, the branches. Those are kind of the levels of their organizational structure were just eliminated, and they put all those people on RIFs. The Office of Smoking Health was just RIFed. The Office of Population Affairs, Population Health, that funds the supports the prevention research centers at our schools. They're all been furloughed with the expectation they'll be eventually RIFed. So overall, within CDC, of those 10 centers, some get to stay as kind of CDC proper. They kind of tend to fall along the, immunization, environmental health, not environmental health, immunization, infectious diseases, preparedness, and global health kind of stay at CDC. Some centers are just eliminated entirely, like the Chronic Disease Center, with no expectation that it's going to exist, but that's what we're fighting for. Then there's some centers that the centers are eliminated, but their programs are going to move over to the new Administration for Healthier America, or AHA. And so the AHA is going to be all of the old HRSA, all of the old SAMHSA, and then some programs, from CDC, that used to live under the Environmental Health Center and the Injury Center and NIOSH. I know this is getting a little long, but it's a weedy question. Over at NIH, I'll just keep that one simple. The proposal there is to reduce the institutes, and we call them ICs, the institutes and centers, from 27 in total currently to 8, and regroup them into fewer center directors that would report to the Office of the Director, to Dr. Bhattacharya. Along with that, reducing the budget by 40%. To about 27.5 billion. That's about an $18 billion cut. So let me just wrap up with that last comment.
Thanks, Mark. I think it's important for people to understand the sort of radical changes that are being proposed and some of which are being implemented. Of course, Congress has to ultimately decide how they're going to fund the NIH and the CDC and other agencies. And they have some ability to direct this, but we don't know how that's going to play out quite yet. Che, this makes me think we need to make sure that everybody in this room has some sense about how best to talk to their members of Congress and their communities, and especially those who are skeptical of public health. And I know you've been working on that. So can you talk a little bit about giving this group a little bit of advice on that?
Yeah, definitely. I was thinking about this term like authority, right? Public health authority. And in the past, that would have meant our leading institutions in this country. But what we saw with the pandemic is that, half the country, you know, rightly or wrongly, didn't trust masking, didn't believe social distancing worked, didn't like the fact that schools were closed, right? If you look at current data now in 2025, another half of the country says they won't trust what comes out of the CDC, right? So it's kind of flipped in terms of what is considered an authoritative source. And so that I think a lot of that comes back to trust, right? And this is something that I know everyone in this room is aware of, but trust is earned. And so a big part of actually, earning trust is by listening, right? So when I talk to folks, leaders, are you listening to the audiences that you're communicating to? For the folks in the room, are you listening to the people in the communities that you serve and that you work with? It's very important that we hear from folks, that we're out in the field, literally meeting people where they are. And that could look like two different things. That could be in the digital space, right? So talking to people on LinkedIn, Blue Sky, right? I hope, Tim, one day you get involved, maybe TikTok or something like that. We'll get you over there. But getting folks, meeting people where they are, right? And not only digital, but of course in real life, right? So of course, folks are gathering now, in-person meetings are back, communicating in person is back. So, taking advantage of those opportunities. And in the community, going to schools, going to faith-based centers, churches, synagogues, temples, going to the barbershop, listening to people, and then taking that, using that information almost like qualitative studies, and then formulating messaging. I think when we talk to the audience, we have to know what resonates with them. I've worked with a partner recently, and we were talking about this idea of structural racism, and they communicate to all 50 states, right? Red and blue. And so this discussion was had about, look, we don't want this term to be a barrier. We don't want to shut off 50% of our audience. The message and what we're talking about in our goal stays the same, but maybe we have to look at this language, or this report could be a non-starter. And so, we took that term from structural racism to systemic inequities, right? The goal still stays the same. I think it's extremely important to consider um, what barriers might exist. And we can go into some other details, right? Like jargon, for example. I was thinking of a term that probably everyone in that room knows, like epidemiological surveillance, right? Like if you're using that in your communications to your audiences, please stop, right? Because the average person does not know what that means, and that's a barrier, right? And that could really impede everything you're trying to do in terms of the language you're using. Of course, where you can avoid partisan language, which is harder than ever now. We saw an attack on the term DEI. We see attacks on terms like health equity. But consider your audience. It's hugely important. And the other thing I would say that's important, and we've seen this resonate with press as well, is focusing on solutions, right? So we know the problems. The problems have been around for a very long time. A lot of these problems are getting worse, right? Chronic conditions and mental health, all those things are not getting better. And so instead of pointing fingers, which is a fun thing to do, I do it all the time, I point fingers at home to my kids. But we need to focus on solutions. And I think that's how we get those barriers to come down, the doors to open on the Hill with press. I've seen press very interested in solutions. And I can provide a few examples later. But I think those are a few key things that folks in the room could and online could focus on.
Yeah, thanks so much, Shay. I think it's so important. That's why we had Mark and Shay, that we think about not only what's going on in Washington and the advocacy we need to do, but how do we communicate? And every one of you has a voice, and every one of you can be communicating at all levels, local, state, federal. And people need to hear from you, because as I said yesterday, public health is under attack, and we need to make sure that people hear from the experts and in a way that they can hear it. The other thing I'll just add to what Shay was saying about speaking plain language, I recently saw the statistic that 53% of Americans have a sixth grade or below education, reading level, excuse me, and 21% are illiterate. So you have to remember that even though we tend to talk to, folks at the PhD level and the master's level, if we're talking to the public, we're talking to a great span of different abilities and knowledge. So we need to make sure that we're doing it with very plain language. Mark, can you talk a little bit more about how we're approaching the FY26 appropriations process and what you can try to predict for that process going forward?
Yeah, sure. So we obviously have a budget, proposed, and what the main bill that we follow is labor, health and human services, and education. That's one of the 12 different appropriations bills that has, all of the public health service, NIH, CDC, HRSA stamps in it. And ARC, which is proposed for elimination once again. And the markups we're expecting to happen probably the last week of July in both the House and the Senate. And that's a aspirational goal. Normally, they like to get these bills done at least through the committee and marked up by the August break. And so far, they start with we call it almost like an elephant train of these appropriations bills. They mark up in subcommittee, then they go to full committee, then they go to the floor, and you have to get all of them. The goal is to get them all through that process, the House and then the Senate, and then to conference, and all done by September 30th. That never happens. We always get onto continuing resolutions when we get to October 1, when the federal fiscal year begins for FY26, and I'm sure that's what it will be too. But I think the big question for this year is, will they get those two labor HHS bills marked up in July or not. So far, the so-called easy bills that normally take like 2 hours to mark up are taking 9 hours to mark up. Things like agriculture, and the Democrats are going in just ready for loaded for bear, with lots of amendments and lots of debate, and it just takes literally all day, and instead of taking just a couple hours, and then you would take that over to the floor, and those bills can be on the floor for days each, and so. What we're going to really look to, I think, on the appropriations process as far as the political landscape is we kind of expect the House bill to be partisan. It always is, where the Republicans will make the deeper cuts there in passive on a partisan basis. The Democrats will oppose the bill entirely. But then the Senate is usually where we see bipartisan bills written on labor HHS. And so the key here will be, can the Democrats and Republicans work together to pass, or at least get out of committee a Senate labor HHS bill. And there was, a hearing yesterday with the OMB director in the Senate Appropriations Full Committee, where Patty Murray was, kind of objecting to things like impoundments that we were hearing about, that they might just not spend money that's been appropriated for FY25. And there's some like trickery, they could call it, it's called a pocket rescission, that under the Impoundment Control Act, they have to say, if they want to, rescind money, meaning not spend it, you're not supposed to impound it. That's illegal. That, they have to give the Congress, a proposal, which they have now done for USAID. And there's a 45-day clock ticking. But after the 45 days, if Congress doesn't spend it, then they're supposed to, spend the money. If the Congress doesn't rescind the money, they're supposed to spend it. And so that bill, rescission bill for USAID and public broadcasting, has passed the House. The Senate's supposed to take it up next. But after that bill's done, however it gets disposed of, what we heard from the OMB director yesterday, that he's leaving his option open, that when we get to like August 16th, there's only 45 days left in the fiscal year. And so they might just propose an impoundment, and the Congress, will have a 45-day clock that runs out before the fiscal year is over, and it's called a pocket rescission. So it's kind of a tricky way of impounding money legally under the Impoundment Control Act. And he basically said, that'll be the president's decision, and that may happen. So we're very much interested in that, because I think the public health community is concerned, especially for things like CDC and NIH, where there's been lots of grants canceled already, and a lot that haven't gone out yet for FY25, that they're going to play this impoundment game, and they're just not going to spend the money. So I think that's a really key thing we're watching for. So I think we'll be holding our breath, probably till August 16th.
Thanks, Mark. You can see why we hire Mark. He knows the details. He really gets to the weeds, which is important. I want to make sure everybody in this room sort of heard about that. I do want to get to questions from the audience and maybe online. Does anyone have a question here in the room? Yes. Can we get a mic way up here? Sorry, it's coming. Of course, it's the farthest away.
Sorry to make you walk all the way up here. Vanya Jones, I'm the Assistant Dean for Community Engaged Research at Johns Hopkins Bloomberg School of Public Health. My question,
You're good.
My question stems from both comments from yesterday and some ones that we heard today. I spend a lot of time trying to get people to work with us at Johns Hopkins to do research with us. And you can imagine that there's a storied experience for people who live in Baltimore. I would imagine that Johns Hopkins isn't the only school that has a storied experience across the country. And one of the things that I've been experiencing with groups of people who have been told that their health is worse, have been told that they've been experimented on, is in fact this idea that in the last few years there's been some terms changes and some inclusion things happening, and now all of a sudden they're being asked to champion for institutions that they don't feel have always treated them very well. And so I think broadly in thinking about using sort of our collaborations and our work, I mean, it's something that I struggle with, right? I spend time as a dean at a school, and I hear people tell me, we're under attack, and things are really hard, and they are really hard. And then I go out into community and say, we need your help. And they say, how helpful have you been to us always in the past?
Right.
And I think, yes, and I think the challenge is, how do we reconcile that message of what are the things that we can say to those groups that have been felt left out that we're now asking to help us? That's the question.
Okay, thanks so much. Yeah, I mean, that's a very challenging question. It's an important one. All the folks here are working at universities that are in communities, and schools of public health work with communities probably more than any school on any campus. And so having that, ideally, you've built the relationship with your community, so they're with you at this point. And having to create that now is almost impossible, right? But I want to turn to Che because I think he might have some ideas about this topic and how best to work with the communities that may be very skeptical of the institutions.
Definitely. And thanks for that question. It's a great question. I was actually at the Bloomberg School about 2 weeks ago working on a great institution. I had a nice coffee at that cafe on the second floor. But a few things come to mind, right? So I mentioned a few minutes ago that trust is earned, right? The other component of that is trust is local, right? And so are the folks that you're talking to, are they seeing you in the community? Are you there, right? Are you present? And not to throw you under the bus or put you on the spot, but have you considered maybe are you the right messenger, right? Like, are you partnering with the local pastors, with the local faith leaders, and being partners with these folks? I mean, that's huge, right? It's almost like when someone emails you and they CC you, and it's like this, a warm handoff, right? A warm introduction. I mean, I can understand if someone comes into the community, and I'm not saying this is the case, but if this was the case, and folks, haven't seen you before, they're not aware of who you are, they don't know anything about you, there could be a level of skepticism, in particular in Baltimore and some of the history that's happened there in the past. And so I think there is a challenge specifically in that community. But I would recommend truly considering who are you partnering with, what other messengers can you bring with you, get them on board, folks that are highly respected, highly regarded in those communities, and bring them in and say, this is what we're trying to do. This is important. This makes a difference. And by the way, we're going to help the health of people in these communities. I would really look at those factors and give it another shot.
Yeah, thanks, Chad. I think that's important. And, it's just very challenging to think about getting partners to speak up for us. But I think many of you are working very closely with partners, either in your communities or with businesses or schools. And we need what people call third-party validators. We need people who aren't at our schools also talking about the importance of our schools and programs of public health in order to make that case. I think there was another question over here.
Yes. Hi, good morning. Vivian Origian from the University of Miami. Thank you, Mark. Thank you, Chair, for your insights. So I think the message of the importance of communication and narratives to mobilize is critical. I wonder if it's insufficient. And my question might sound a little bit naive or even border in ignorance, but the conversation started like, okay, we thought this was going to happen, and then we're looking and observing almost in a reactive mode to what happens, right? We are a science built on going upstream, not downstream. So are there mechanisms? Now we're seeing that the government is working very differently from it has ever been. To the extent that many of our colleagues ask, where is Congress? To what extent Congress can do anything. So are there mechanisms or ways to really anticipate rather than react with what we have learned is happening, which is the executive branch is working its way almost without the chance of having others catch up. And the legal system is trying to play catch up. So are there any ways that we are unaware of? Have we thought about this? What are our options?
Mark, you started off talking about being reactive versus proactive. Can you go into that a little bit more?
Yeah, sure. And I think part of it is the Elon Musk factor. I mean, here's and members in the MAGA movement. Let's be honest with everything here. I mean, this is a new phenomenon. So yeah, we can anticipate this was going to be the congressional reaction. And that they're going to, one, the Republican Party wants to come in and control spending, and that's a legitimate public policy that we want to reduce budgets. And Elon Musk kind of came along with like money to help them win the election to have the trifecta. Two, then they kind of feared him personally for like if they try to become a roadblock to what he was doing as a Doge, that he would attack members of Congress, which he did, and then they worried that he was going to take them out in the next election with his money, and part of it was just it was a matter of convenience, I think, for the Republicans, that it's easier to let the Doge kind of run its course and do all these kind of budget cutting exercises without having to go through this laborious congressional process is really, what's the whole checks and balances is built upon. So they kind of created a brand new system that never existed before with the Doge to go through, let's just cut spending in FY25. And we're still fighting over that. It's still playing out its course. And, it's, evolved to the point that, Elon Musk put $20 million into a Senate or a Supreme Court case, a Supreme Court justice election in Wisconsin, and he lost. And then that's when things started to change. And Republicans started to find their voice a little bit more in Congress, and then Elon Musk has kind of moved off the stage a little bit now, and had a little retirement party at the White House, and physically is not as involved as he was, but his Doge operatives are still involved and still doing their work, and I think that's about to shift back over to the congressional process. Certainly, when we start marking up FY26 appropriations bills, I decided that's already been underway in some of the other subcommittees, but it will happen, by the end of July, I think, for HHS, and that's when we are there. We've been lobbying that. We had our Hill Day. We've been talking to the members of Congress. We haven't seen their decision making yet for FY26, but I doubt they're going to go along with a 40% cut to NIH. I don't know how much of CDC they're going to try to reassemble, but we're going to find that out. But I think the fact that we've been in there, advocating for these things, they were hearing our input, they were letting this other process play out. That's about to run its course, and I think we have to just stay with our game plan.
Yeah, thanks, Mark. And I just want to add that ASPPH is very committed to trying to not just be reactive. You saw yesterday, we released the Healthy Longevity Report. Now, we believe that report actually is something that the Make America Healthy Again agenda might resonate with, and members of Congress might resonate with, because we're talking about trying to prevent illness in later life, right? And we think that there are chances for us to at least try to have those conversations with those who don't necessarily agree with a lot of the work that we do in public health, but try to meet them where they are and hear what they're saying. I'm not saying we would give up any of our principles or our values, but we want to try to figure out, are there some things that we can do that are more proactive? So I really appreciate that question. Are there any questions from online, Liz?
Yes, but we can go to the audience here. Did you have one? Okay.
Thank you so much for this really excellent session. I'm Pam Factor-Litvak from Mailman School of Public Health at Columbia. So I'm really concerned about these gold standard of science tenets and how they're going to be implemented. Implemented.
Yes.
And in particular, so I'm an epidemiologist, and I know that much of the work I do is very context dependent. So reproducibility, if I'm working in India, there might not be a reason to think that it's relevant to the US, although I try to make the case now in particular. We all want to think that our research is unbiased, but it's not. And, I can poke holes in things I do and in things everybody else does. Those are just two really basic examples. So how are these, if these are really going to be the standards in which our research in public health, which is more of an art almost than a science, going to be judged? How is this going to actually be implemented by NIH, CDC, review panels, et cetera, et cetera?
Yeah, that's a great question, Pam, and I think it's something that many of us are quite concerned about. But unfortunately, I don't think we quite know how they're gonna interpret those terms and how that's gonna affect public health. But I'll ask Mark to see if he has any ideas.
No, I'm still struggling with how to pronounce falsifiability, but I think I've mastered it now. Hypothesis, but no, I don't. I think we just have to wait and see how they, with the people at NIH or want to do that. I mean, clearly, I think a part of it was like to kind of fund science that may have been discounted or not funded in the past. I mean, they, folks that may have not gotten through peer review get a crack at federal funding in a way that may have not been kind of mainstream. And that seems to be kind of what, I'm just reading between the lines, listening to what Dr. Budgetary has said in the past. I mean, they've kind of come on, they've been described to be called like the contrarians, coming out of the Stanford, folks that, with McCarty and Scott Atlas, and that, that they've, I mean, obviously, I mean, be honest, I mean, that, he was described to be a fringe epidemiologist by Francis Collins, and we need, during the COVID, debate. And, I think it's kind of, he's coming in trying to correct, maybe, what may be seen as an institutional bias against funding alternative views in science. That's kind of my best crack at it right now. But
yeah, I think that's absolutely right. I see another question back there, Liz.
Thank you for your wonderful discussion. And I wanted to ask, how much do you think we need to be doing advocacy for our students? That's a population that needs advocacy. They are in school for 2 years. They pay tuition. Their income after they graduate is not that great. And now there are not enough good jobs. I cannot, in all honesty, recruit students and say, in 2 years, look what is awaiting for you. I hope in 3 years something is awaiting for them. But what is the advocacy? Because we say we need to build trust. So we need to be building trust for those who are going to be future public health workforce. And I think I am always cognizant that about 50% of the population in US said they don't trust what is going on. And we need to be cognizant of not just administration, but our population, our people, and see how do we build that trust. And unless we advocate for the future public health workforce, in all honesty, and we advocate for everyone, every individual in the United States, then we haven't done the full advocacy that we need to do to move the needle.
Thank you. So let me just say a couple things about that. First of all, we work very closely with all the schools and programs through our This is Public Health initiative, really trying to give students a voice for their concerns like this about their future. And we also have a storytelling initiative going on right now. We want to hear from you and your students about this field, but I also want to make sure that we don't frame it too negatively for our students. Yes, it's a challenging environment today, but I do believe that the training that they're getting in public health can be applied on any number of issues and in any number of fields. So while it may be challenging, let's say, to get a job directly in a public health department right now because they're worried about their funding, it doesn't mean that they couldn't get a job working for a nonprofit or for a for-profit organization that needs the minds of people who think like we do in public health. So I want to encourage everyone to be encouraging students to say, yes, it's more challenging, but there are still opportunities and you can still make a wonderful career out of a public health degree. One other thing I want to mention is we created the Now More Than Ever campaign this spring to really try to make the case to people who were applying that they should apply for their master's in public health, but also to try to make sure that they were going to matriculate. Because we all know we get a lot of applications, you all get a lot of applications, but we want to make sure that they actually matriculate. And so we're trying to give you the tools and the resources to do that. And all of this is on our website, but it is challenging, but I just want to make sure you understand there are some ways to respond to that.
Yeah.
Liz, do we have any questions online? I want to make sure we're not missing those. Oh yeah, Mark?
Just in response to the last question, Tim, just want to point out that we did make one of our top priorities advocating for enactment of a public health loan repayment program, which got authorized. And then the next part of this is to come back and get it appropriated. And we haven't been able to get that appropriated, but that is something we have fought for as a key priority so that our students would get, I think it was like $105,000 in loan repayment over 3 years for 3 years of service in public health. So substantial thing that focuses on the students. While we're talking about that, though, I will say in the reconciliation bill, what the House has done is taken out the Grad Plus loans and eliminated that program. So we're worried about that. The Senate parliamentarian just went through the help section of the bill in the Senate and knocked out a lot of House passed restrictions on the loan programs. And there was like 6 or 8 of them that got knocked out, and we call the bird bath process. It's a little technical term, but meaning it's going to have to come out of the Senate version of the bill. So I think that's a good thing.
Yeah, that's very positive. Liz?
Great. I'm going to take this question in 2 parts. So this first one, Che, is probably for you. What's the process of pushing articles out for press coverage of topics that impact public health?
That's a great question. I mean, on a very simple level, right? It's like getting the facts or getting the W's, right? The who, what, when, where, why, making sure it's timely, making sure it's relevant, and selecting the audience, which outlets you want to target, and pushing it out there, right? It's a pretty easy process. It sounds easy, but it's not that easy. But it can be highly effective. And I was kind of sitting on this story, hoping I had an opportunity to share it. Sounds like I might have an opportunity now. So here at Burness, we were brought on to tell stories about Project Echo. For those who don't know, Project Echo was founded out of the University of New Mexico, and it's basically a hub and spoke model. The hub is a specialist, and the spokes are general practitioners, right? So the idea is that they extend their knowledge, right? So we were brought in to talk about a Project Echo, frankly, all over the country, but this one particular incident happened in Chicago. So folks on the ground were doing diabetes care, right? And some communities in Chicago have a 30% rate of diabetes, which is about 3 times the national average. And what was at risk is this Echo was about to lose their funding. The funding was there. It was tied up on a political level and the state level, like bureaucratic red tape, all this stuff. So the plan was to utilize media to unlock these funds. So we got with the 2 doctors on the ground, one general practitioner, another endocrinologist, got the data from the local level. And the other big piece outside of data, and I think I mentioned earlier, is really about people, telling stories about people. How's this going to affect somebody's grandmother or your neighbor, right? So you have to include people in these stories. We got these stories, got the story package, sent it out to a few reporters, and a wonderful reporter by the name of Jennifer Gore, who writes for Word in Black, wrote the story. So we had a piece. What happened with this story, it was picked up by a local paper in Chicago, the Chicago Defender. A week after that ran in the Chicago Defender, miraculously, those funds were released and an RFP was put out for the state. So, I mean, we're not necessarily taking direct credit for that, but it does show like the power of media and the power of press to change narratives and move the needle, in particular on very important policy initiatives.
Yeah, I think that's so important. That's a great example, Che, of a way for all of us to be able to speak out. And I think these stories you can tell from your work with the community especially are going to be very strong. And we can help you with that. You all, most of you have press people at your universities who can help you. You also have government relations staff who can help you traverse the hill. So we encourage you to take advantage of those resources. I see that we're getting close to the end of the hour, so I think we're gonna have to wrap it up here. But I wanna, first of all, I wanna thank Che and Mark. Can we give them a round of applause? And then I know I'm not seeing any slides, but we are going to have a recording of this on our website soon, and we are going to have other webinars coming up. The next one is July 7th, and I hope you will join that webinar as well. We're trying to do more webinars in order to help everyone hear what's going on and have a chance to engage with ASPPH. I hope you all have a wonderful and productive day today. And that if you have any other questions, feel free to come up and ask me. Happy to talk with anybody. Thank you so much.